My name is Dr. Paulette Maroun. I'm a gynecologist in private practice in the city of Sydney. I've been in private practice for nearly 25 years and I love what I do. I'm interested in talking to women about their gynecological health and getting them to understand their body better. I think it's important to remove the myth around certain conditions that are quite common. And by a little education, we can do that together. This is really based on my experience. I'm summarizing these conditions for better understanding, and whatever you feel that may apply to you, don't try and treat it yourself or get the sense of false security. Go and see someone. The idea for this podcast, having a few drinks with some friends, shooting the breeze under a flowering jacaranda tree nearly a year ago. And my friends were asking me questions. And I thought, wouldn't it be good if we made this information available to everybody? And at the time, I thought, it would be great to have a podcast. And it took us a year to make it happen because of fear of failure, fear of saying the wrong thing, giving the wrong education, somebody getting hurt. But it is supposed to have, to be a helpful podcast. And there are so many specializing in different things. This is a general podcast based on what people usually ask. How did I get into gynecology? How did I get into medicine? Basically, somebody said to me that I was good in anatomical dissections when I was doing biology. And I used to take the rats home for the kids to see. It was really an interesting time. And I thought, somebody said I could be a surgeon, so I might do that. But it was mainly, the wanting to help people and interested in the workings of the body, the anatomy. I love anatomy. And be able to help people is such an honor. Yeah, it's a privilege. The favorite parts of my job are from the beginning, from meeting the woman for the first time or the couple who come in with a medical condition or with a question, and asking questions with passion and compassion, and getting the history behind the person and behind the real medical condition. So the medical condition is one, and behind it there is a person that has, a history, emotional, physical. Yeah, and it is beautiful to get to know people. I love the mystery work, like what could it be? I like to ask questions about their life and their other other organs, other systems, not just gynecology, so I can get to know them better. And I love the surgical part. So we'll start with PCOS. So PCOS stands for polycystic ovarian syndrome. And traditionally it is called PCOS. And it's a combination of symptoms and signs. So the symptoms are the things you experience, and the signs are the things we establish by investigating. So in the past, a number of follicles of 10, more than 15 millimeters on any ovary, we would call it PCOS. So a lot of women were given this label falsely, especially if they had, no other symptoms. So now they've made it harder to diagnose. And to diagnose polycystic ovarian morphology, you need to have 25 follicles on the ovary. The ovarian size need to be a certain size, but it would not be called, a lot of women would have PCOM, but not necessarily polycystic ovarian syndrome. So for it to be called a syndrome, it needs to be associated with irregular cycles, which is the most important thing. And I'm not talking about plus or minus 2 days or plus or minus a week. It's usually quite either short, very short of 2 weeks, or prolonged for, 8 weeks. Some women only have 3 periods a year. Some women don't have a period at all. But in addition to this irregularity, there are androgenic symptoms. The androgenic symptoms are acne, oily skin, hair in the male distribution, hirsutism, which is hair growing on the upper lip and on the chin, around the nipple areas, and in the middle of the abdomen between the umbilicus and the pubic hair, and anywhere else. But also it could be like this kind of distribution, maybe, in women of certain culture. So it might not be like because of androgens, right? So these are the main androgenic symptoms. Obesity is another symptom, difficulty losing weight. Insulin resistance is not part of the diagnosis as yet. The severe cases are associated with cardiovascular disease. We call it a metabolic disorder, high cholesterol, high sugar, diabetes, heart disease, hypertension. It could be quite severe in some women. And infertility if the cycles are not ovulatory.
What is
okay. Ovulatory means that they ovulate every month, producing an egg for fertility reasons. And those women who have a lot of estrogen on board because either of obesity or because they're producing a lot of estrogen because of the PCOS, and they're not shedding it monthly or every 2 months, there is an increased risk of endometrial cancer. So these are the worst cases, but a majority of women have mild cases, and they're quite scared of infertility. So the most important thing about this condition and the diagnosis is that if you have regular cycles and you are ovulating, which is, we can do a test for that, then it's unlikely you're going to have problems with fertility. So PCOS is now called PCOS. The name is going to change to a metabolic disorder syndrome, so that the emphasis is mostly on the worst conditions, not the mild conditions, so that the women are relieved from this diagnosis that they live with all their life thinking we're going to be infertile. I think the importance of knowing whether you have PCOS or not is that you seek help early and you don't leave your fertility till quite late, because if you do run into problems, there are medical treatments that help with ovulation, and if that fails, you can go for IVF. So if your life dreams come before the dream of a baby, then it can be a problem. That's why it's important to know early and be informed so that you can make the right decisions for yourself and your life. The other condition that is quite common is adenomyosis. So adenomyosis basically is a form of endometrial cells inside the muscle of the uterus. So it causes blood blisters in the muscle of the uterus. So these can be a cluster and they look like a fibroid on ultrasound, or they can be widespread in the uterus, in the uterine muscles, and it causes the uterus to be bulky and bigger. So it causes heavier and more painful periods. So we use it as a condition to, like a differential diagnosis when somebody comes in with heavy and painful periods, right? Sometimes we find it on ultrasound. You find like little black windows in the muscle of the uterus. It isn't a cancer. It is not endometriosis. It's a condition that, causes pain and heavy bleeding. It doesn't cause infertility. The treatment is like any treatment of the symptoms. So treatment of the heavy bleeding and the pain. So with, tranexamic acid perhaps, or taking the pill or something like that. Yeah, we don't know that much about it, but if you have it, you have it. So if we find adenomyosis in somebody who's postmenopausal, it doesn't matter really, because they're not bleeding, they're not having pain. Yeah, it doesn't cause any symptoms outside the time of premenopause. Endometriosis was described in 1917. We've been studying it since, and we have we have more information about it than when it was first described, but we're still learning about it. And I believe the government had put a lot of money into the study and research of endometriosis because it is quite common. It causes women to miss out on work, so decreased productivity of businesses. It also can cause distress for the women, and you have to think, well, once a month they're going to take a day or 2 days off work. It's hard to, for the woman who experiences this pain, especially if it's severe, to flourish, because they know they can't, apply themselves. This is if it's not treated. The problem with endometriosis, so the symptoms of endometriosis are pain, and the degree of pain varies with women. Pain with the menstrual period, classically with the menstrual period, right? So if the pain occurs outside the menstrual period, it's unlikely, like a crampy pain outside the menstrual period, it's unlikely to be endometriosis. It can cause pain with sexual intercourse on deep penetration because the endometriosis in the pelvis can be touched. It can cause pain on opening bowels, which we call dyschezia. Some women have cyclical bleeding from the back passage if they have endometriosis around the bowels. These are, the common symptoms. We don't know who has infertility with it. The degree of endometriosis in the pelvis, whether it's grade 1 or grade 4, may lead to infertility or may not. So the degree of the visual endometriosis in the pelvis doesn't tell us whether the women are going to be able to have babies or not. And classically, we always tell the story that, there are women who have had their babies, and we used to do tubal ligation at laparoscopy for contraception. And we found that a lot of these women had severe endometriosis, but they never complained of severe pain, nor did they have infertility. So we don't know. This is the mystery about endometriosis. The similarity between adenomyosis and endometriosis is pain, and the pain is a crampy pain, central, while with endometriosis, it does not cause heavy bleeding. Adenomyosis can. So you could have the two conditions together and you could have heavy bleeding, but classically endometriosis does not give you heavy bleeding. What it can give is premenstrual spotting. So the spotting of the bleeding starts 1 or 2 days before the period, but not the heavy flow. So in terms of diagnosis of endometriosis, diagnosis is also not an easy one. You go by the history. So you ask all the right questions, and examination is also important. Pelvic examination is important because you might be able to feel deep endometriotic nodules in the pelvis on the support of the uterus when you do a vaginal examination. But if the endometriosis is like freckles around the pelvis, we're not going to feel it. It doesn't mean the patient doesn't have pain or the woman doesn't have endometriosis. It just means that she doesn't have deep endometriosis that I could feel on examination. Now, pelvic ultrasound can pick up an ovarian endometrioma, which is what they call it chocolate cyst, which is a blood-filled cyst. Sometimes the cyst is a hemorrhagic ovulatory cyst, so we need to repeat the ultrasound, and if it's still persistent after 3 months, the same or increased in size, it is more likely to be an endometrioma. And if a woman has endometrioma, then she is more likely to have pelvic endometriosis. That's the only thing we can find on ultrasound that is specific. Now, there are some clinics that do deep endometriosis ultrasound, and they will pick up on deep lesions because they can feel them. They can measure them if they are large. Again, if the endometriosis is just blood blisters in the pelvis that are not bulky, we're not going to pick them up on ultrasound. So medical treatment includes anything that suppresses the ovaries or decrease the blood loss, or that suppress the endometrial lining, not so much the blood loss. So classically, the oral contraceptive pill, those women who can't take the oral contraceptive pill can have progestogen-only preparations like Implanon, the Mirena, Depo-Provera, and Nurofen, of course, if the pain can be treated on its own without the use of the contraceptives. Now, if these fail in treating these symptoms, the option is surgery. So the laparoscopy is the diagnostic tool. You enter the abdomen, you see the pelvis, you see the lining of the pelvis, you see the endometriosis. You take a biopsy, send it away, make sure that's what it is. It might sound simple, but surgical management of endometriosis can be associated with complications. So you don't want to jump into doing a laparoscopy first, especially if you're able to take the contraceptives and you don't have any side effects with it. It gives you good pain relief. It doesn't make you less fertile if you don't have your surgery straight away. So knowing about it is also a tool for you to have so you can make informed decisions, because some women with it may have infertility. So also you don't want to leave it for too long before you think about having a family. So this is where it becomes important, knowing the diagnosis or a possibility, a suspicion of endometriosis. Like a diagnosis doesn't need to be made, but a suspicion of it, so that, we can say, try and have your family early, or consider it as a priority, because you may run into trouble. And then you will require surgery and then, time to recover, or you might require IVF. The earlier we know, that's the importance of knowing. Well, that's a very interesting question. The women see a gynecologist. Who do the men see? No, the equivalent, if men are having fertility issues or have urological issues, they see a urologist. Should the women be cleaning inside the vaginas? No. The vaginas are, I'm thinking of a nice word, what's the word? The vaginas are equipped with microflora that keeps the pH in the vagina acidic, so that although they are exposed to the external skin, which can have bacteria on it, fungi, candida, the milieu in the vagina, because of their acidic pH, discourages the overgrowth of these, even though that they are found in the vagina. But they don't overgrow and they don't cause diseases. In addition, the vagina has an excellent blood supply, so infection risk in the vagina is very low. The most common conditions infections in the vagina are associated with the pH being more alkaline, including candidiasis and bacterial vaginosis. And I'm not talking about STI infections. These can occur in women whether they're sexually active or not. But although they can occur without being associated with sexual intercourse, they can be transmitted to their partner. So if we are treating candidiasis or bacterial vaginosis, we should also treat the partner if he doesn't have any issues with or allergies to those medications. Otherwise, they keep giving it to each other. A UTI in women in young girls can be common because of the anatomy of the urethra. It's very close to the skin. So if there is a hygiene problem, they can get urinary infections. Most of the adolescent gynecology are really specialized because they can be genetic disorders, they can be bleeding disorders. So the girls may present with very, very heavy bleeding because they can't clot properly. So adolescent gynecology is massive. Pap smears are interesting. Abnormal pap smears are most likely associated with a HPV infection, a human papillomavirus. People know HPV as a wart virus. Warts, however, are benign, but some of the cervical infections that are associated with high-risk HPV can cause cervical cancer. Now, Australia's done extremely well with screening, inviting women for screens, newly self-collected swabs looking for active HPV, and the vaccination program. So all of these measures have reduced the rate of cervical cancer in Australia in comparison to a lot of other countries who did not employ similar programs. So we're very lucky to be here. Now, the education behind it is everybody who is sexually active carry 4 or 5 HPVs, and they lie dormant in the vagina, the cervix, the vulva, around the anus, and also in the throat. So there are 40 HPVs that infect the urogenital tracts. Only 15 cause cervical cancer. Number 16 and number 18 are the most common. And these were the ingredients in the first HPV vaccine that was given to school kids, boys and girls. And the others we lump under others because they're not as common, even though they are still high-risk viruses. It's just so expensive to do all the typing for all HPVs. So we only do 16, 18 and other. And this covers all the high-risk HPVs. Now, we have a combination of low risk, meaning like they're not as severe or as significant, and they can cause warts. But it's very important to know that the HPVs, the low-grade HPVs, can cause wart infections, and some of the wart infections, unfortunately, can have cancers in them. So it's very important to seek help if you have any vaginal lumps or labial lumps. Now, I know some of the questions that we've received is about labial or vulval cancers. It is associated with a lot of conditions because the skin of the labia is the same as the skin on your hand and over the body. So you can get melanomas in the labia. You can get a lot of other skin conditions that can turn into cancers like lichen sclerosis, but also HPV can cause labial cancers. And women would present either with a lump or itchiness, yeah? So it's very important to know that the skin on your labia is the same as everywhere else. So if you see a dermatologist, ask them to look down there because it's very important. And the importance of HPV testing. So now everybody whether whatever they identify themselves with, whether they've had sexual intercourse or not. It's important to start to have the vaccine and have pap smears. Yeah, it's very easy. It's free. It's simple. It can save a life. Oh, Papa Nicolau. So Papa Nicolau is a Greek doctor who was interested in the cervix, cervical abnormalities. I don't know how he came to know that there are some abnormal cells. I can't remember the history. But he wanted to know more about the cervical cells. So he used to subject his wife and her friends to gynecological assessment of their cervix every day of the month. So he can work out what the cells look like at different times of the cycle and whether this is normal or abnormal. Very clever man. A cycle. I'll start with a cycle. So a cycle, an ovulatory cycle can range between 26 days and 31 days. And the period can last for up to 7 days, and it could be normal for a person. The flow, I don't know many people who know how to measure the blood loss, even if they're using a menstrual cup. So changing a regular pad every 3 hours on the first and second day is normal. However, if you know your period to be lighter than this, and suddenly it becomes heavier, even if you're changing 3 times or 4 times a day like a normal person would, but this is different to what you have experienced, then that becomes abnormal. Abnormal is if you have large clots in the flow. Small thready clots are fine, but large clots can mean that the blood loss is so severe that the blood can't come out through the cervix quickly. So the blood sits there and then comes out like a big jelly, right? That's definitely abnormal. Bleeding in between menstrual periods is abnormal. Bleeding after sexual intercourse is abnormal. These are the things that we look for. A woman knows what her normal period is, by flow. This happens every month. That's what's normal for her. Any changes is not right, and she needs to get some help. So young girls basically, and sometimes athletes who over-exercise and are very lean, my understanding is the steroids that are produced, so they're produced from fat. The steroids can change to estrogen and progesterone and testosterone. So if there isn't enough fat in the body, then they can't have these hormones, so they don't get a period. But this is not how we have periods. We have periods from the pituitary gland. It produces follicular stimulating hormone, which stimulate the ovary to make eggs. And then once you have enough estrogen, the lining of the uterus thickens. And then if you ovulate, you produce progesterone, which stabilizes the lining of the uterus, waiting for a pregnancy. If no pregnancy occurs, you get the shedding. But it is quite complex. I don't really know why exactly that happens. But I do know that, menarche, which is the first time girls have their periods, is becoming a little bit later than we know it. It's because women are leaner these days. There's a social expectation of the women to be lean. So they're reaching menarche a bit later. So the vagina itself, if a baby hasn't gone through it, is intact. The pelvic floor can become very tight and cause what we call dyspareunia, which is pain on entry. And that is because either the vagina is dry, so if they are breastfeeding, there's less estrogen, so there's no lubrication. Or if they are on, let's say, some the Mirena or progestogen-based contraceptive pill that can make the vagina drier, the mucus drier. So there's no lubrication. And then they've got pain because of this. So the pelvic floor becomes really tight because they're trying to protect themselves from pain. And so the relaxation of the pelvic floor muscles. So it might not be because they had a cesarean. It could be breastfeeding. It could be dry vaginal discharge because of, waiting for the period to start again. And HPV infections can cause vulval cancers. So Mittelschmerz is described by Mittelschmerz, and it's pain associated with ovulation. Not many women would have this awareness of their ovaries ovulating, and we don't know how some women do. So sometimes it's from the right ovary, sometimes from the left. Why it happened after delivery, I don't know, but it's a sign of ovulation. If they want to block it, you block the ovarian function. Perimenopause is a description of a certain stage in women, the years before menopause occurs. So the definition of menopause is 1 year of not having a period. We call it 1 year of amenorrhea. So the conclusion of 1 year is menopause. So perimenopause are the years prior to menopause when some women get irregular cycles, maybe heavier periods, maybe lighter periods. They may sometimes have, hot flushes, occasional hot flushes, but classically they have irregular cycles. And the reason for that is they're not ovulating every month. So they're running out of follicles, and so they don't ovulate every month. And the lack of estrogen and progesterone may make the cycles quite irregular. They may be shortened or prolonged. And they may be associated with some symptoms of low estrogen, even though mostly they are still within normal limits. Because the ovaries are still producing estrogen, but not enough to cause an ovulation. It is a time when, it probably, there's subfertility associated with it. What's important about it is to recognize it, right, as this is perimenopause. So unless you see a doctor, do a pelvic ultrasound, make sure, and blood test, make sure these changes are not related to abnormal thyroid function, abnormal prolactin, some other conditions that can lead to irregular cycles, some structural pathology. So a series of investigations need to occur to make sure that they are normal. And if they are normal, we say, okay, that's perimenopause. Otherwise, it's difficult to diagnose. So the hormonal tests are not helpful, like to see if your estrogen is normal, FSH is normal. But what's good about perimenopause is preparing for menopause. So we need good nutrition. We need to have more protein in the diet so we don't lose muscle. We need to do resistance exercises to protect our bones from osteoporosis. Decrease alcohol to save your brain as well, like your brain cells. Learn new things, be active, sleep well. So start looking look after yourself really well in preparation for menopause, because you're so different to a younger you. Sometimes perimenopause occurs really early, and it's very important to seek help so that we could do genetic testing to see if there is any genetic predisposition. Sometimes we fail to find out why early menopause occurred, but we need to support that body. We need to make sure that the bones are healthy, we don't get muscular wastage, and we keep our brain active. We come to conclude our first podcast, Viva La V. I found it very interesting. This is my first podcast. Thank you very much for dialing in. I hope you found it informative. I hope we offered you some more education about your body, and you feel empowered. If you have any issues, or if you think that you need assistance, go and see your GP. In this country, we have excellent GPs who care about patients, who are very specialized. And if they are concerned about you, they will refer you to a gynecologist with all the investigations that is required. If you have any comments, if you have any questions you would like us to cover next, please let us know. Write us a comment. It's been an honor to serve you. My name is Dr. Paulette Maroun. Thank you.